Hello and welcome to my channel. I'll be your preceptor today. For the next few episodes, we're going to focus on basic cath lab circulator and nursing knowledge, just basic. You transferred from ICU, ER, any other floor. If you're a new grad, whew, I have much respect for you going straight into the cath lab. We're going to just kind of look on like practical hands-on. What do I need to know? What do I need to do as a new to cath lab nurse? As always, um, this is kind of general information on what you need to do in the cath lab as a circulating nurse. Um, for any specifics, please refer to your hospital policies, procedures, talk to your on the ground nursing preceptor. Um, so let's get started. Um, for this first episode, we'll kind of focus on first aid basics. First of all, welcome to the Cath Lab. Um, Obviously, you've chosen to transition to a procedural area from probably bedside. Um, a lot of you experienced nurses are coming from the emergency room or ICU, and you've taken care of STEMI patients either as they land in the emergency room, kind of getting them teed up to go to cath lab, stabilizing, giving that heparin, giving the aspirin if it wasn't given by EMS, or you've worked in the ICU, so the post cath lab area, kind of seeing them post procedure, seeing them after their LAD, circ, whatever vessel was opened, um, if they ended up on Impella or a balloon pump or something like that. Um, I just want all of you to keep in mind that no matter how many years experience, 2, 5, 10, 6 months, whatever, you're coming to the cath lab, this transition is overwhelming. Okay. It can be overwhelming. There's just another aspect of nursing that you're going to learn. Um, but I just want you to keep in mind every day when you get overwhelmed that you know how to take care of a sick patient, right? You know how to keep that patient alive. Okay. There's a lot that you also have to add into your basic nursing care now that you're in this very niche um, procedural area. But look, take a step back, take a breath. You know how to be a nurse. You know how to take care of this patient. Okay? Don't lose, don't get too overwhelmed in this transition. It's very easy to do because there's just so much to do. So, what is the cath lab? Okay, we all kind of know it's a procedural area. It does minimally invasive procedures on the heart or other blood vessels, most commonly known for their STEMI care. You know, you got that 90 minutes from door to balloon time. They're going to the cath lab. We're opening up a vessel, hopefully getting this patient feeling better. But cath lab is way more than STEMIs. Um, you also see them take care of those NSTEMIs, those non-ST elevated MIs who came in with chest pain but just don't have the EKG changes. So they don't necessarily get rushed to the cath lab when they land in the ER. They can sit on the floor with like a heparin drip for a day or two. If they're unstable otherwise, they might sit there for a few more days before we bring them to cath lab. Um, cath lab will also do heart failure and pulmonary hypertension diagnostic testing. Let's do that right heart cath. We'll look at your pulmonary pressures, kind of like a swan for you ICU nurses. Get those pressures, get those SATs, kind of take a look at all of that. We will bring abnormal stress tests in there to do a coronary angiogram, the abnormal cardiac CTA follow ups, and then outpatient procedures. A lot of these NSTEMIs or even STEMI patients will have multiple vessels that have areas that need to be addressed. And if they're stable and healthy, we'll send them outpatient, let them kind of recover from the hospital stay, bring them back outpatient. Um, Depending on your lab, we also will place transvenous pacemakers. Those will be your emergent third degree block patients that come into the emergency room, the symptomatic bradycardias who need a quick pacemaker. Um, we place permanent pacemakers, ICDs, new technology, and these CCMs. Those are for heart failures. We can talk about that later on. Some labs, not all labs, usually depends on kind of like a cardiovascular surgeon backup. They will do structural heart procedures. These are your TAVRs, your SAVRs, your PFO ASD closures. Other labs will also do the PE thrombectomies, they'll do DVT thrombectomies, cold leg management, so those arterial clots, EVARs, so your AAA repairs. Renal nerve denervization is a new technology that's just coming out that's being done in cath labs as well. So cath lab does a lot, not just STEMIs. And so this is why sometimes it can be a little overwhelming. Um, that's okay. We'll get through it. We'll learn. All right, so first day, let's talk about the team that's going to be in the cath lab. The one thing that I enjoyed when I first went to cath lab was that you're never alone. You're never going to be that one nurse, ICU nurse, taking care of 3 ICU patients, 2 ICU patients, the one-to-one sick patient that you're in there constantly. You're never going to be that ER nurse who has like 5 patients that you're trying to take care of, 1 or 2 that are like super sick, need ICU, can't get them there. That's not going to happen in cath lab. You're always going to have 1 patient. There's going to be 1 patient on your bed, and you're going to have at least 2 other team members plus a physician for every procedure. Never alone. Just nice, right? Some labs also run 4-man teams. So you'll have 3 other staff members plus the physician for every 1 patient. Okay, so who are these team members? So first of all, you're going to have a scrub tech, whether that's a RCIS, a RT, a scrub nurse. This is the team member who's going to be sterile. They're going to be at the table with the physician. They're going to kind of get the patient ready for the procedure, get the equipment that the circulating nurse is handing off, prep it, get it ready, and be hands-on in the procedure with the physician. Um, there's a monitor person. So this is also either a tech or a nurse, kind of depending on the facility. And they're going to their job is to document. So they're going to document what's going on in the procedure. They're going to take vital signs. They're going to watch that telemetry. They're going to record kind of like what's going in and what's going out of the body if stents are placed. So that's going to be their role. Um, in a 3-man team, this monitor person is the circulating nurse's best friend and should come out and help you if you need help in a pinch. Then, depending on your facility, the circulating person is either the same as the sedation nurse or a separate person. So the circulator is a tech or a nurse who pulls supplies. So the physician is at the table, they're wanting a different guide, wire, stent. We'll talk about all of that. But that person will go get that equipment and go open it for their scrub tech at the table so that it can be used in the procedure. Again, so in a 4-man team, this is a separate person. In a 3-man team, the circulating person is the same as the sedation nurse. So the sedation nurse, which is your 4th or your 3rd person, that's you, most likely, going into the cath lab. Okay, you're going to sedate this patient. Fentanyl, Versed, you're going to give all the emergency medicines if you need to, like atropine, start Levophed, start dobutamine, start Integralin drips, drop any medicines that need to be dropped on the back table for the procedure. So you'll be responsible for like making sure your patient is doing okay, making sure they're breathing with the sedation, if they need oxygen, all of those things. So that's going to be your sedation nurse. Sometimes the sedation nurse is also circulator, so you'll have to do all of the medication parts, making sure the patient is doing okay while also grabbing equipment, which can be a lot sometimes. You'll also have, as your physician, you're going to have your invasive cardiologist. It could be either a diagnostic only physician or interventional physician. Diagnostic only physicians can, like the name says, they can only do diagnostic procedures. So let's say your patient had an abnormal stress test. So your diagnostic physician is going to come in, get access, take some pictures. If it's a clean cath, that's it. You're done. If it there needs to be intervention, then they're going to have to the procedure will be paused, and they're going to have to call an interventional uh, cardiologist to come take over or make decisions. Your interventionalist is an invasive cardiologist. He's the one that's going to balloon angioplasty, put in stents, do your thrombectomies, um, whatever needs to be done. These physicians also can put in the transvenous pacers in emergencies, even if they're not an EP specialist. So these are going to be your doctors that are on your STEMI calls. Also, if your facility does electrophysiology, you're going to have electrophysiologist physicians. Um, These are the physicians. They can be dual trained. So you can have your invasive cardiologist / EP person. They'll be the ones who do your STEMI call plus put in permanent pacemakers. Um, Electrophysiologist specialists do your pacemakers. They do your micra, which is a type of leadless pacemaker. And they do your cardiac ablations. So your AFib ablations, your A-flutter ablations, etc. So just kind of depends on your facility. Not every facility has a diagnostic physician. Not every facility has a just straight EP specialist. Um, Hopefully they have a EP trained physician who can put in your pacemaker plus do the invasive cardiology. So let's look at the actual procedure room. Um, you're going to need a couple things to be able to do any procedures in the cath lab. So you're going to need the procedure table. Obviously, where's your patient going to go? Okay, this table is mobile. Okay, so your patient is going to lay typically supine. Sometimes if you're doing some of these leg procedures, they can be prone on this table. But for like STEMIs and hearts, basic cath lab procedures, they're going to be on their back. And this table's going to move. It's going to go up, down, left, right. Um, and your scrub tech or your interventional cardiologist is going to be moving that table throughout the procedure. Um, Everything usually on top of the patient becomes sterile when they're draped, and um, kind of knowing your facility's protocol on how we're going to strap these patients on. Usually like a leg strap at minimum so that the patient can't roll off the table. Very bad. We don't want our patients rolling off the table. You also will have your x-ray machine. So usually this is a C-arm. That's that C-shaped x-ray machine that kind of moves around the table. So your table's going to go up and down. Your C-arm's going to go left, right, forward, back. That's so that you can get different angles of the heart, see different anatomy. Important to make sure that you don't get hit by the C-arm when you're up there doing something for your patient. Because it can swing towards you, and hopefully your scrub tech and physician are paying attention and don't hit you with it. There's also the surgical boom and your monitors. So in the lab, there's going to be a TV screen where those x-rays will pop up real time. Again, your C-arm's going to move. They're going to take an x-ray. The x-ray is going to pop up on the screen so that your physician can see the vessels. So is the LAD occluded? Is the RCA occluded? Is there anything we need to do? That's going to be real time. So let's touch base on the C-arm. And we'll also really touch base on radiation safety in this episode because these are kind of the big things for your first day. So the C-arm is your x-ray machine. Okay, You'll hear people call it C-arm. You hear people call it II. They're the same thing. Okay, this is just an advanced imaging system. It uses fluoroscopy to get continuous X-ray imaging. Like I was saying before, it swivels so that you can go different directions and see different anatomy for these patients. So you can really see the vessel that needs to be seen, see it clearly, get different angles so you really know what's going on. Um, Very important to keep in mind. The x-rays come from the bottom of the C-arm, not the top. So if that bottom part of the C-arm is facing you and they're on fluoro, you're getting blasted with x-ray. Um, Hopefully, sometimes the physician is very aware, kind of paying attention if you're up there, kind of switching out oxygen, giving medicine, that they're not going to blast you with x-ray, but just something to keep in the back of your mind that the bottom of the x-ray, if it's pointing directly at you and they're on fluoro, you're getting blasted with x-ray. So what we talked kind of about the C-arm. It's called a C-arm because it has that C shape. Um, but where does the term II come from? Which is also another term that you'll hear. Hey, can you move the II? C-arm, interchangeably used depending on your facility. So II stands for image intensifier. It's the technology actually within the C-arm that allows the C-arm to use lower intensity X-rays, but get that nice, intense, bright image so that the physician can see what they need to see. This image intensifier technology helps decrease the amount of x-ray that's needed during these procedures, but still get that clear image that's really important to see those vessels. Another x-ray technology that you're going to see in some facilities, again, not in every facility will have the C-arm, not every facility will have the biplane. So the biplane is a secondary x-ray imaging system. um, it really focuses on kind of the lateral imaging. It helps give the team a dual imaging view so that they can get more detailed images. Um, this is supposed to lead to decreased procedure times, lower radiation. Some of the studies say that this isn't really necessary in the coronary arteries, which is why you won't see it in most of your facilities or some of your facilities, sorry. Um, it's just doesn't always lead to less procedure time and radiation just for heart procedures. It is most commonly used during the neurointerventional radiology procedures. So those stroke patients, they will almost always have a biplane. They're a little bit more small, like smaller vessels. You really need to pay attention to what's going on, so it'll give a more detailed imaging for those neuro rads. So let's talk about radiation safety. This is really important in this procedural area. As like a ER nurse, as an ICU nurse, you kind of have some radiation safety information in the back of your brain. But in Cath Lab, you are constantly working around radiation. Um, that C-arm is blasting, you're getting all these images. Um, and so it's really important to kind of keep in mind radiation safety for not only yourself, but your patient. um, of radiation exposure mitigation becomes kind of one of your top priorities. So there's a couple different protective devices that are used that are just in the lab. So you'll see like the lead table skirts that sit between where your physician usually stands on that left side of the bed and your II or your C arm. So it kind of helps block some of that scatter radiation from getting to your physician or your surgical tech or whoever's on that left side. You also see kind of ceiling suspended shielding that's used that they can move around so they can block more of that scatter from getting to your physician and scrub tech. Your physician and scrub tech or scrub nurse or whoever's at the table, they're at the highest risk for radiation exposure because they're right there in the whole procedure. But as a circulating nurse, as a sedation nurse, you're still in that room. You're still kind of going up to the patient, whether it's to like change oxygen When they're moving, you got to kind of keep them from moving, whatever. So you are getting exposed. And usually you're on the right side of the bed instead of the left side. So the left side is usually where the physician and the scrub tech set up. As a circulating nurse, you're not going to want to go near the sterile stuff. So you're going to be on the right side, kind of popping in, changing oxygen, whatever. There's not usually as much um, protective devices on that side. So just be cognizant and kind of get in there, do what you need to do, and get out. You also have your own personal radiation garments. So these are going to be your lead aprons. So we'll kind of talk a little bit more in depth. They're definitely, you got to make sure that your lead aprons fit. You got to have them on every time you're in there when the fluoro is happening. Um, Something else you can get is lead glasses. So that's going to protect your eyes more from like cataracts. There's also some lead shielding for your head. Um, there's been some studies that brain cancer comes out from increased radiation exposure. Um, so again, as a circulating nurse, you're kind of moving around. You're not always right there. You don't have as high of a risk as like the physician who's constantly standing there. It's something to keep in mind. And then your facility should provide a thing called a dosimeter. Um, Travelers will sometimes get it through their agency, but this is something that you're going to wear while you're in a procedure to measure how much radiation exposure you're getting exposed to. Important to wear it. Please wear your dosimeters. Send it in, however, like monthly, quarterly, however often your facility sends them in. You're going to wear one at shoulder level. It's important to wear it at your shoulder level outside of your lead. This one monitors how much X-ray exposure you're getting to your eyes and your thyroid. Um, Not every facility gives you a second one. If you do get a second dosimeter, this one is worn inside your lead, like in a pocket. Your most lead aprons have pockets, but you want to wear it inside your lead. It's kind of measuring how much X-ray exposure your organs are getting. So you'll get a report when you send it in. Um, if you're above 5,000 on your dosimeter report in a year, it's a lot of X-ray exposure, and usually you'll be pulled out. So kind of depending on how much X-ray you've had, you might not be able to work for a month because you have to come out and let your body kind of get that radiation exposure out of your system. Again, that's all facility based on your limits. You should have a radiation specialist at your facility. Every facility's x-rays should have a radiation specialist, and they will keep an eye on that and be like, hey, you're reaching your like limit on radiation. Let's pull you out of um, the procedure room for whatever amount of time. So talking about lead aprons, go back to that topic. Um, they should be worn by every person that's inside the lab during the procedure. Again, very important, right? Protect yourself. Make sure your friends are protected. You get a code blue in that room, people from the ER, ICU are running in to help you. Make sure they have lead on, okay? Help them kind of put it on correctly because it can be confusing, and it's important to help your friends stay safe. Properly fitting lead garments keep your vital areas from getting too much X-ray exposure. Again, X-ray exposure is bad. Radiation, high radiation levels is bad. Uh, it's going to really come into play for your patient who doesn't get that, but you, as a person in the cath lab, are getting repeated doses. So, as females, a lot of these lead apron tops are made for men. Okay, that is all things. So you really need to be cognizant of your breast tissue in that armhole. Okay. Try to make sure. I like to pull mine up when I'm wearing a men um, size top. Recently got my own kind of fitted lead, so it covers my breast tissue much better. Um, but those large armholes leave breast tissue exposed, and it increases your risk for breast cancer. Nobody wants that. You need to keep your abdomen covered, protect those vital organs, keep your femurs covered, your pelvis covered. cover those long bones, okay, where a lot of that blood is produced. Uh, Blood cancers, no bueno. Okay, keep your thyroid covered. Thyroid cancer sucks. Don't do it. There are a couple different styles. You can have one piece styles. So some of majority of the one piece styles are just going to cover your front. Okay, so it's going to cover you from about your neck down to your knees, but not give a lot of protection for your back. So if you're wearing a one piece but no back coverage, just be cognizant of turning around and having your back facing the x-ray. Um, there are other one pieces that have cover your whole body, just kind of wraps around. Another style is two pieces. So the two piece apron. So the two piece apron is going to have a skirt that wraps around. You're going to wrap it around your uh, waist, and it should go down to your knees, covering those femurs. Um, and then you'll have a couple different options for your top piece. You can get one that's like a vest, so it goes on from the back, Velcro snaps in the front. And then you can also have the one that's a little more complicated. It goes on the front. It has a strap that puts it over the shoulder, and then two straps to wrap it around the um, bottom at your hip. So just be aware of what kind of lead that you have at your facility. Make sure you ask somebody to help you get a lead that fits appropriately and know how to put on your lead properly. And always get a thyroid cover. It's kind of weird sharing thyroid covers when you're new and you don't have your own. Um, it's not as bad with the lead apron, the lead top, because you have your scrubs on, but the thyroid cover touches directly onto your skin. I mean, from personal experience, I got a lovely little rash from a shared thyroid color cover from a shared thyroid uh, lead piece. They sell thyroid covers on like Etsy. Buy something fun, wear it over it. Just remember to take it off so nobody uses your thyroid cover too. And then lead glasses, if you want them. Again, like I said, a lot of this is going to be for your scrub tech because they're at the table. Um, it just kind of helps decrease the X-ray exposure to their eyes. You can get it as a circulating nurse. Whatever makes you feel safe. It decreases the risk of cataracts, which is increased with the exposure to X-ray. So we have you covered. Let's just touch base on radiation safety for your patient that you should keep in mind as you kind of move forward in these procedures. So your patient is going to be naked under a drape. They're going to get blasted with these x-rays directly because we're seeing their vessels. So it's really important to monitor the amount of radiation that we're giving the patients during the procedure. Um, Radiation is not benign. Large amounts of radiation can lead to both short and long-term complications. Um, Radiation burns, hair loss, whether temporary or permanent, need uh, skin grafts. And then, also we were talking about cataracts and cancers for staff. Same thing with patients. So long-term increased radiation exposure can lead to these kind of complications in patients as well. And keep in mind, especially if you're doing staged procedures, the dose is not one day and then the next day they're fine to get as much radiation as you want. It's a cumulative effect. So if you give 3,000 milligrays of x rays a day and then they're coming back in 2 days for a stage like circ fix, they're kind of high on their x-ray exposure and you should keep that in mind. So we will watch for dose monitoring of radiation during each procedure. Your x-ray should just kind of give you a number. And really, the hotspots are the 3,000 milligrays. It's still a safe procedural area, safe exposure area, but you're getting close to getting to a dangerous level. So we really should start talking about, should we wrap this procedure up? Should we be finishing? Usually 3,000 milligrays are where you say, hey doc, we're at 3 grays, just so you know, so that they can kind of hopefully wrap up the procedure. 5,000 milligrays, you've reached your radiation safety threshold. So the patient is now at high risk for radiation complications, whether this is just the mild radiation burns, erythema, hair loss, we've reached that threshold. At 7,000 milligrays, you have a mandatory radiation safety review. So your radiation specialist is going to come in, take a look. Why did we give this patient that much? And they've reached complication levels. And it's very important that, and it won't be really you, but your physician needs to follow up with very specific follow up for these patients. Because, yeah, they get a red little rash and they go to their PCP. They're gonna be like, yeah, yeah, no big deal, but it is, right? But the primary doctor doesn't know that they got over 7 grays of X-ray 2 days ago during their cath procedure. At 9,000 milligrays, this patient is going to get desquamation. They're going to need really close medical monitoring. And then about 10,000 to 12,000 milligrays, it's considered a sentinel event whether your patient is alive or not when they leave the lab because they've gotten so much X-ray that the risk of complications is high. So whether your patient is alive or not, it's a sentinel event and has to be reported as appropriately. So, that's just what I want to touch base for your first day. That's a lot of information for your first day. It's just kind of basic safety, basic what's going on in the cath lab. Um, we'll kind of touch base on moving forward. I was talking about catheters. Talk about that probably next episode. If you want anything specifically talked about, please just leave a comment below and I can make a video about whatever you would like. Thank you for listening. I would love any feedback where I can make these videos more helpful for you in the future. Um, thank you so much. Good luck.